Well, it's 1:15. Thank you very much for coming right after lunch. I know probably more people will be coming in as we proceed. So I think we're going to go ahead and get started. We have very, very exciting program with amazing speakers today. And it wouldn't surprise me if this is going to be the best symposium here at the APAO. So we have total of 6 speakers today. One of the speakers got injured, so he was not able to make. So we have a little extra time. So for the speakers who's here today, if you go a few minutes over, that'll be perfectly okay. So we're going to allot about 15 minutes per speaker. So about 10, 12 minutes, and then 3 minutes of questions and answers. So I think this is going to be very nice and interactive because we're going to be covering a lot of interesting topics that I think everyone will truly enjoy. So I will introduce the first speaker, and we're going to go and get started. The first speaker is no other than Ken Nischel. He's Advances in Management of Corneal Opacity from US. Please. Can we have the slides up, please?
They're up. Perfect. Thank you very much for inviting me to speak in this session. Okay, so how many people in the audience manage corneal opacities in children? And that's even just seeing them. Susan, put your hand up. These are my financial disclosures. None of them are relevant to the talk. So Peters anomaly, I've been saying this for a long time, actually now about 26 years. It's a bad term. This is a picture of a child who was thought to have sclerocornea. When you do the UBM, the lens is attached to the cornea. That's supposed to be Peters anomaly type 2. So which is it, sclerocornea or Peters anomaly? As a result of that work that started when I was a fellow, I came up with a new classification, and the classification is this. Basically, there's primary corneal disease and there's secondary corneal disease, right? Primary corneal disease, the only things that are primary corneal disease are corneal dystrophies, corneal structural defects due to dermoids, and this condition called CYP1B1 cytopathy. I'm not really going to talk about that very much, except that in certain cases of congenital glaucoma, you don't have Harb's-Tree, but you have a hazy cornea. You control the glaucoma, the cornea remains hazy. This is called CYP1B1 cytopathy, and it's been published a lot. And then I'm going to talk about the secondary corneal diseases, and we'll get through them. It's important that secondary corneal diseases are developmental or they're acquired, right? So it becomes a logical step as to how you approach congenital corneal opacities. This is the algorithm I use to decide how to manage a child that presents with congenital corneal opacity. They get a clinical evaluation, and I rely on electrodiagnostics, and then they also get a systemic evaluation, and if possible, if it's available, I do genetics. I want you to note that sometimes you cannot do anything, either because of the family circumstances, or because of the child's illness, or because of the severity of the condition. But otherwise, there's a whole range of things that I'm going to talk to you about that you can do. Here I've put first that you must manage the glaucoma. If you do anything without managing any secondary glaucoma, it's going to fail. So let's go through the different things that we can do. This is a child who, I'm showing you this because I have a very good video, but basically the child had had congenital cataract surgery, congenital glaucoma surgery, and had a decompensated cornea. So because I have integrated intraoperative OCT, I was able to do a DSEC. And what you're seeing here is that I used a pull-through technique with a suture, and the endothelial graft is hanging there at the moment. And what I'm going to do is I'm going to inflate the eye with air. Now, the way I do these cases, I do the inflation, I make sure there's apposition. The child then goes into the recovery for about 2 hours, still sedated, then comes back into the OR so I can check the pressure and check that the endothelial graft is opposed. You see that is total apposition. In children, you do not need very thin material because over a period of 6 to 8 weeks, the endothelial graft thins. So it's quite difficult to do a DMEC in children, but this is about 100 to 120 micron DSEC. Now, this is done. Child goes into recovery, comes back, pressure was good, I'm happy, child goes away. This is exactly 6 weeks later. You do not need to do a penetrating keratoplasty when the stroma is clear and the problem is the endothelium. All right, so DSEK. What about deep anterior lamellar keratoplasty? I published about this the first time 15 years ago. You can tell that I'm getting old because everything is in decades, not a couple of years. And what we talked about was the use of DALC in mucopolysaccharidoses. Now, if you are in a region of the world where you cannot do enzyme replacement or bone marrow transplant, then it's better to do a PK. Why? Because the endothelium becomes damaged if the children have not had a bone marrow transplant or are not on enzyme replacement therapy. But if they are, then a DALC is much better. And here, what I want to show you is that there's a double layer here. The first layer is Dua's pre-decime layer, and it's very easily viewed in children. And sometimes I have to use the OCT because the separation is not perfect, but here afterwards you can see that I've put the DALC on, and this is what it looks like at the end, and it's really quite remarkable. This is just to show you that if you get right down to decimes, you get a really good result. It's as good as doing a PK, but much safer. All right, so we've talked about DSEK, we've talked about DALC. What about other conditions? So here's one that actually Parth Shah, my ex-fellow, showed in the other room. If you have a very large dermoid, right, people worry about having to do a lamellar keratoplasty. As long as the bed of the dermoid is no more than 250 microns, then we've published this technique. And the technique basically, I'm going to talk you through it, is in A, on the top left, in A to D, A, B, C, D, what we're doing is we're taking away the lipodermoid. Once you take that away, you close the conj, let the child recover. 6 weeks later, you come back, you take the corneal dermoid off, and then you do an SLET. How many people know what an SLET is? So it's a simple limbal epithelial transplant. You take a 2 by 2 millimeter straddle across the limbus, which is shown up in this one here, and then you cut that 2 by 2 into 8 pieces. That's the most difficult bit. Then you place those pieces with the corneal part towards the center on the bed with glue, and then you can either put amniotic membrane or a bandage contact lens, and look what happens. The recovery is remarkable, and you get some stromal regeneration as well as epithelial. So you do not need a lamellar keratoplasty. So if you're in a part of the world where getting tissue is difficult, you can do this. But if it's more than 250 microns, you will get ectasia. If it's 250 or less, this girl was done 11 years ago, she's developed no ectasia. So sometimes it's better to do it and then come back later when you've got material to strengthen that area. Okay, and that's what, again, what it looks like. And I've now resorted to using this technique even in simple limbal removal because I get no scarring or very little scarring. Okay. I don't have a timer here. I hope I'm okay for time. They're not, okay. So now let's talk about what people call Peters anomaly. Sorry. I have a reaction to that term because if I say Peters anomaly, let's say to the gentleman at the front, what is Peters anomaly? Just shout, what is Peters anomaly?
It's a corneal dysplasia.
Corneal opacification. So what's the difference with what kind of opacity? With the iris? Without the iris you can't have Peters anomaly? Oh, so you can have with or without? Or there can be posterior defect. So do you see what I mean? We're using one diagnosis for all these different types. How is that accurate? How is that accurate? So here we are. This child has some iridocorneal adhesions. He was sent to me from California, and we did the visual evoked potentials that showed that one eye is seeing better than the other eye. So I decided that I was going to do selective endothelial removal. This is how you do it. You use low aspiration, 20 millimeters of mercury, and with the OCT, I know that I'm not damaging decimes. I am aspirating the diseased endothelium, and you'll see that I go into a little bit into the clear cornea. Why? Because you want to get rid of the barrier that's stopping the healthy endothelium from growing into the diseased endothelium. So low aspiration, some people use a silicone tip, that's fine, but low aspiration, and at the same time, in this case, I did an optical iridectomy. So I've taken the optical iridectomy. Oops, I've gone forward too much. So that's what I did. I always do an optical iridectomy with selective endothelial removal to speed up the visual rehabilitation. The mother doesn't live close to me, so she sent me these pictures, and you can see from, so remember this is written in American, right? So 9th is September, and 12 is December, right? We do this month first. For over 3 months, look how much it cleared. Now, in this case, you cannot do selective endothelial removal because there's an excavation and decimase is gone. If you try to do selective endothelial removal, you're going to damage the cornea and you're going to get a big opacity. So do you see how the phenotype determines what you can do? When you say Peters anomaly, it's like, look, at the moment, there's a cough. Now, I know it's just a simple cough, but if you say somebody's got a cough and that's the diagnosis, they could have a cough for any reason, and the treatment changes with the reason for the cough. So if we don't change our terminology, then continue to get everything wrong. So in this case, I did penetrating keratoplasty. And in the last follow-up is visions 20/70 for near, both eyes open, 20/40, 20/70 for distance, 20/40 for near. Okay, the last one is when you have glaucoma and ectasia, I do something called a sandwich technique. So as you remove the diseased tissue, you close it again with an 8O nylon. Why? Because you don't want an expulsive, all right? Your end-tidal CO2 should be 30, and you give mannitol. You really want to make the eye soft. Now, you are going to lose some endothelial cells, but lots of visco, and you put the new graft over. And once you have done that, you cut the 8O nylon on the host, and you pull it out. And that way, the eye is always closed. It's called the sandwich technique, and it's a technique I use when the glaucoma has been bad and there's ectasia, because I do not want an expulsive hemorrhage. So, on that note, I was asked to talk about advanced techniques. Don't be afraid. If you would like to learn these techniques or become part of the International Congenital Cornea Network, please scan the QR code. There's a registration form. Join, and we will be having a virtual meeting in June. We already have 472 people across the world who believe that these children who are born with congenital corneal opacities need more care than we are presently giving them. Thank you.
Thank you. Great job. Any questions? We have probably time for one or two. That was an excellent talk, by the way. That was the first time I've seen the sandwich technique. I think that's ingenious.
It wasn't my idea. It's been published by another group.
I think that's ingenious.
It's a very helpful group, but you have to accept that you're going to lose some endothelial cells, but it's better to lose those than the eye.
The second speaker is Prof. Dodesa with the Advance in Understanding of Retina in Abusive Head Trauma and Current Understanding.
Thank you. So I think I actually like to kind of walk around a little bit. So I'm going to be talking about the current research on abusive head trauma and the retinal findings for 2025. And this is an area that I have a lot of passion for. And so let's just briefly talk about the retinal hemorrhages and also the etiologies. As you know, when you see a child coming in with a retinal hemorrhage, the differential diagnosis can be quite extensive. When after all those things are ruled out, then you can possibly think about the abusive head trauma. But the problem is that there's a lot of disagreement in terms of the pathophysiology and also the findings. And so that's where that's how the research got started, because I actually had a patient with the retinal hemorrhage, but we actually had some disagreements, and this case had to go all the way to court, and the outcome was very undesirable, and it just made me feel horrible. So the first dilemma is that there are many, many different medical causes that can cause retinal hemorrhage, and so are the traumas. And the second dilemma is that how do you know if something was truly accidental or if it was intentional? I mean, these are very difficult questions that one has to address. So the accurate diagnosis is extremely critical because the false negative, can you imagine taking this child back to the home of the abuser and the child end up dying? And as you know, these things happen. But the false positive has just as much bad impact. Think about what it does to the family. As a matter of fact, in the United States right now, we're not talking about the accuracy of the diagnosis. There's a case, there's a gentleman who's on death penalty for child abuse right now from Texas. So getting the diagnosis accurately is extremely critical. So my aim was to use AI for assistance. See if we can, there's lots and lots of technology out there. So I wanted to take advantage of the AI. And number two, I wanted to estimate the force just based on looking at the retinal hemorrhages. Just estimate if that retinal hemorrhage is consistent with the history or not. Because if it is not consistent with the history, then it requires further investigations, of course. And lastly, I wanted to look at possible treatments. Because many of these patients, as you know, have severe cortical vision impairment as well as the amblyopia. So I wanted to see if there's something that can be done. So I'm going to try to address all that in the next 8 minutes. So retinal hemorrhages, when you look from far away, they look somewhat similar. I mean, you've seen retinal hemorrhages from diabetes, macular degenerations, and it can be very, very daunting. But if you look very carefully, each one of those hemorrhages have special patterns that we're not going to really go over during this talk, but they all have unique findings, and there's a reason for that. So we collected images from different parts of the world, from Korea, US, and Australia, of different various causes, and we broke them down into medical and trauma cases. And these are confirmed cases of trauma cases. So if it was an abusive head trauma, it was confirmed cases, it was court confirmed, or multi-specialist confirmed that it was a result of abuse. So these are not equivocal cases, these are confirmed cases. And then they were labeled, and then we had 5 experts around the world and looking at these images, and we annotated them. What does that mean? So we identified, delineated the retinal hemorrhages, and then we looked at whether it's a pre-retinal, intraretinal, or subretinal. And if there are areas of retinal schisis or retinal detachment, it had to be specifically annotated. So it was a daunting task, and we took lots and lots of time. And then these images had to be pre-processed and then augmented. What does that mean? So pre-processed. There are many types of retinal cameras out there. As a matter of fact, if you look at the exhibition hall, there are more coming, and as a matter of fact, there are actually retinal image cameras coming right now. That's not on the market. So within the next 2-3 years, I think it's going to be very exciting. But many of these images were taken by different cameras with different lightings, different sizes, different frames. So it had to be pre-processed to make it uniform. And then we had to augment it. So what does that mean? So every time the model was asking for a new image, the AI would generate an image by rotating it, by flipping it, changing the brightness. And by doing this, the AI actually can expand the number of images and make it more accurate. So this image can be flipped and rotated and framed in a different way, like this. So for example, here, this is me. But if I provide images with wigs, like this, remember, this is still me, so the computer, the AI, would have a less chance of misidentifying who I am. If I show up with different outfit, different hairstyle, different makeup, you see, it can still identify that it's me. So and then it had to go through a deep learning. What does that mean? So these images had to be broken in and down to small filters. I'm going to just kind of explain this. Small filters, and these filters are combined and analyzed in layers, as you can see there. Then each layers they're built on each other, on the previous ones, and then you start to form a very complex patterns. And then by analyzing many different images this way, then you can start to recognize patterns that it has never learned before, that has never seen before. And then on top of that, you can recognize patterns that we ourselves cannot recognize. For example, males and females. I can't do that. I don't think anybody can here. But it can start to identify things that we just don't recognize. So what we found that the accuracy of our program was about 95 to 96% of differentiating medical versus trauma. What does that mean? So here's our first image. Here. Okay, here's our first image. As you can see, this is an actual diagnosis was from a trauma, and the AI would give us the medical predicted probability was 2.15%, but the probability of it being traumatic was 97%, so it was accurate. And then for the medical diagnosis, it was the same thing. And then the big question is, how do you know if something was accidental or if it was intentional? Okay, so this is very, very difficult because is the retinal exam, you could actually rephrase this and say, is the retinal exam consistent with the history? Is the force applied to the retina based on history consistent with what you see in front of you? So for this, to answer this question, we developed a very complex and a finite element computer simulation model, not just the eyeball, but including the muscles, orbital fat, the orbit, the skull, the entire headset, as you can see here. And we had about 1 million small points that we could analyze simultaneously when we do something to this eyeball. So for example, here, also we were looking at the optic nerves. We wanted to see exactly what happens to the lamina curvosa. We wanted to see exactly what happens to different layers of the retina and the sheath as well. And then we shook this eyeball like this, similar to the doll model. So when you shake this model, similar to the doll model, we're able to see the exact vertical, horizontal positions. Not just that, we could see the velocities and accelerations and decelerations of this eyeball at all million points simultaneously at a thousandth of a second, which is almost impossible for us to do. So here, this is what we saw. So when you look at the retina, the average stress was about 7 kilopascal along the vessels. What is 7 kilopascal? This thing right here, applying force, like putting this on a table, that's about 7 kilopascal right here. So that's about the amount of force that I'm applying to the blood vessels. And wherever there was a bifurcation of the blood vessels, because there's a more direct contact, there's an adhesion of the vitreous to the retina, there's a greater force of 9 to 10 kilopascal. And that's the reason why you see retinal hemorrhages in all periphery, not just in the macula, because there are more bifurcations in the periphery. And then when you look at the pre-retinal, intraretinal, and subretinal, all three layers, they're all similar. The amount of force that was being applied to these three areas was very, very similar. Now, this is going to become very important in just a little bit, okay? So now we looked at all different types of sports. We looked at baseball, soccer, pickleball, and we wanted to see exactly how much force is being applied to the eye in what patterns. So here's a pickleball hitting the eyeball, and this may just seem like a very simple picture. There's actually a lot that's going into this picture, because remember, we can analyze any points in the retina at thousandth of a second of 1 million points. So what does that mean? So here, you can see the force. As it contacts the cornea, that force is being propagated in a translational fashion, moving back and forth and back and forth. So there's a vibration. And if you look very carefully, I'm going to just show you that force is it's very positive initially, and then as it bounces back, it creates a vacuum. It's almost like a pulling force, attractional force. Probably that's what's resulting in retinal schisis. And another thing is that, as you can see, most of the force is concentrated right at the optic nerve or the macular area. And that's also, when we look at all three layers, you can see the greatest amount of force is being applied to the pre-retinal rather than a subretinal layers. And that's probably the reason why you see more pre-retinal hemorrhages, more concentrated in macular area in patients with sports. I'm going to show you some pictures of that. And also, with the abusive head trauma model, with the oscillation, with the shearing force, the force continued to climb versus the force of the trauma, which declines very, very quickly at a 1/100th of a second. So it's a very different type of pattern. So when you look at the hemorrhages for abusive head trauma, it's pretty much all in the periphery wherever the bifurcations are, but in the sports, it's mostly central with possible retinal schisis. So what we're doing today, right now, is that we're collecting more retinal hemorrhages, and using AI, we're trying to, by looking at when the picture is provided to us, we're trying to quantify the force based on retinal images. And then what we're doing is that that's going to help us to determine whether the force that was applied to this retina is consistent with the history. And if it's not consistent with the history, then you're going to have to assume there's something else to the story that requires further investigation. Okay? Remember, our job is not to determine if something is abused or not. Our job is to determine whether the picture is consistent with the force that was applied. That's it. And then what we're doing here is that we are doing animal studies with mice, monkeys, and lambs. And so here's a mice. Oh, sorry. I'm going to... I had to keep this video pretty short. Oops, sorry, it's not working. But I didn't want to show, right after lunch, I didn't want to show mice being shaken at 5 hertz. It doesn't look very pretty. But these mice these are 6-day-old mice, and we shake them at 5 hertz for 5 minutes, and we're looking at the retinal structures along with OCTs and SLO-ERGFAs, and then histology and immunohistochemistry. And what are we doing? Why are we doing this? So when we look at the OCTs and FAs and ERGs, and also the histology, there's actually a lot of things that we're finding. For example, look at this histology, and you see the melanin that's dispersed from the RP into the photoreceptors right here. And it's being released into the photoreceptors. And we don't really know what this does to the photoreceptors, and also specifically the Mueller cells, which I'm going to talk about just a little bit. And also, you can see this. You can see the RP layers splitting as well. So what we're doing is that we're specifically looking at the impact of the melanin in the photoreceptors, also the Mueller cells. The Mueller cells, as you recall, it's kind of like a pillar of the retina. It starts from the external limiting membrane all the way down to the internal limiting membrane. It's the only cell that expands the entire retina. And during this force of shaking, the shearing force is probably causing some disruption of these Mueller cells and causing some type of dysfunctions. And we're using RNA probe to look for the cell function of the Mueller cells to see what is exactly happening. And so we can find the biomarkers and potentially find some treatments. And these are as you can see, this is a humongous, it's a huge, it's a daunting task. And we have a huge team all over the world that's helping us. And if you're interested in helping us either with providing images or providing any feedback, this is my email. And please send it to me, and I welcome any questions. Thank you.
Thank you, Professor. Very interesting presentation. If you have any question, please ask to Professor.
I know this is going to take some time for you to just kind of sit and think it through because I put in about 3-4 years of my life into this. So if you have questions, I'm going to be around, and you can please come to me and ask me. And I feel there's so much more into this. There's so much more. As a matter of fact, some of this project is being presented tomorrow at the Trauma Conference, the American Society of Ophthalmic Trauma, tomorrow. So if you have questions, please come and look for me after the meeting. Thank you.
There's one question.
Oh yes, please, Ken.
Fabulous work. The only thing I'm a little confused about, I've seen more macular schisis in documented non-accidental trauma than accidental trauma. But in your presentation, you were saying that you see more schisis in the traumatic, or at least that's the picture you showed.
Yeah. So thank you very much. The question was that do you see more the pathophysiology of macular schisis? Do you see that more with trauma, or with the accidental trauma versus a non-accidental trauma? I'm just going to tell you this: the picture that I showed was from a motor vehicle accident. So the force has to be pretty significant for it to travel translationally and hit the macula and create a vacuum to tear the retinal tissue. The amount of force that's required to cause retinal schisis, we're expecting about 20 kilopascal, which far exceeds the shaking. So you really have to, so the first thing, number one, the force has to be pretty significant amount of force to cause retinal schisis. So if a child fell and you see retinal schisis, that's inconsistent, number one. And number two, if you see retinal schisis in a potentially abusive head trauma, the amount of force is significant enough that you should really see significant amount of retinal hemorrhages in the periphery. Because remember, the amount of force that's applied to the blood vessels at the bifurcation is about 10 kilopascal. And the retinal schisis has to exceed that. So the amount of force of shaking has to be pretty significant. By the way, when we shoot these computer simulation model, or the baby dolls, it was only at 2 hertz. It was 2 hertz. So you're talking like this. We intentionally made it 2 hertz so that it's pretty easy to do. But if you're shaking at 3 hertz with a lot of anger and intensity, that number of 10 kilopascal can reach the 20 kilopascal. Thank you very much.
Thank
guys.
you, Donnie. Just I had one curious question.
Yeah, please.
This is an excellent work, and I agree it's a humongous work. Just had one curiosity. What happens to the woodpecker's retina?
Thank you. Thank you. You know, I'm actually very happy right now because these questions are great. The woodpeckers, you know, the lawyers, when you go to court, the lawyers will make a comment. How about the woodpeckers? They don't have retinal hemorrhages, and they're vibrating at 3 to 4 hertz. So they're shaking their head 3 to 4 hertz. Number one, there are only very few animals. Actually, I learned about. You remember, I studied the animals. There are only very few animals most of the mammals are not holoangiotic. So the monkeys, the humans are holoangiotic. That means that every single cells have blood vessels reaching it. You understand? But woodpeckers are not holoangiotic. It lacks the blood vessels. It only has very few blood vessels. Number one. Actually, there's a lot more. Sorry. Number one. Number two, the lens of the eyeball is just like the mouse. The reason we have to shake the mice at 5 hertz instead of 2 hertz is because the lens occupies about 90% of the vitreal space. So the lens provides a lot of cushion. And the birds are the same way. That they provide a lot of cushion. And the vitreous is much dense, much more dense.
Thank you.
Thank you. Thank you very much.
Thank you very much. It's my pleasure to invite Dr. Hyun Jin Shin, who is going to talk about what's new in pediatric neuro-ophthalmology. Over to you, Dr. Shin.
Okay, so Thank you for your kind introduction. I'm from South Korea. My name is Jin. And I would like to thank you, Dr. Seo, and organizing committee for putting together this wonderful session. And the topic of my presentation is what's new in pediatric ophthalmology. Unfortunately, I have no financial disclosure. And to begin, I ask ChatGPT, please draw a picture that is the topic of today's presentation. And it creates this following image. Interestingly, artificial intelligence technology like this already is being used in the field of pediatric ophthalmology. Previously, Donnie saw beautifully describe how it used in traumatic retinal hemorrhage in pediatric cases. Today, I will talk about three main topics: advancing diagnostic technology, and updating treatment, and newly emerging diseases. By the end of this talk, I hope we will all gain a clearer sense of how the future of pediatric ophthalmology is evolving. Let's start with advancing diagnostic imaging. Here is an OCT image in the past and now, and recent technology advancement have led to development of a handheld OCT combined with a fundus camera. So these are now available not only emergency setting but also widely in pediatric ophthalmology. Especially these tools are used for evaluating optic disc swelling and monitoring pupil edema. With the integration of AI technology, real-time detection of diseases have become more accessible. The Bonsai deep learning system analyze over 15,000 fundus images and demonstrate excellent performance in detecting pediatric pupil edema, achieving an AUC close to 0.99. This technology helps clinicians distinguish true pupil edema from normal or abnormal optic nerve, even in remote or underserved area. AI research is also expanding beyond the imaging, beyond just the analyze static imaging, and into dynamic eye movement analysis and strabismus diagnosis using auto-segmentation technology. Now let's talk about treatment. Virtual reality devices are now being used not just for gaming, but as digital therapies. Luminopia, for example, is an FDA-approved digital therapeutics for treating amblyopia. In South Korea, digital devices have been approved for treating homonymous hemianopsia caused by brain lesion and commercially available. These digital therapies are especially effective in children because they are engaging and user-friendly. These tools are now being used to help children with cerebral visual impairment, CVI, which is a leading cause of visual impairment in children with special needs. A study using Vision Nanny, a web-based platform for children with CVI, showed that all 35 participating children aged 9 months to 5 years demonstrated improvement visual attention and engagement. Overall, digital intervention was found to be more effective and received a higher satisfaction rating compared to conventional methods. There are also advancements in pharmacologic agents. Optic pathway glioma represent about 5% of pediatric brain tumor and occur 15 to 20% of the children with neurofibromatosis type 1. MEG inhibitor target the overactive RAS pathway, blocking the MEG enzyme to reduce tumor growth. This drug can be taken orally, not IV, and cause less immune suppression compared to traditional chemotherapy. Let's move on to the last topic, newly emerging disease. The first emerging condition is visual snow syndrome, a neurophthalmic disorder characterized by persisting flickering dots across the visual field. Patient may also experience after image polynopia, plotter, photophobia, and dictalopia. This condition, first defined by Dr. Granty Liu, a neuropediatric ophthalmologist in Philadelphia, is often misunderstood. In our recent study of 63 patients, 22% experienced symptoms before their age 15. But unfortunately, many were initially misdiagnosed as just having vitreous floater regardless their age. So in visual snow patients, filter glasses such as FL41 lenses can help alleviating their symptoms. Also, I believe that patients should avoid refractive surgery like a LASIK in adulthood, as these may worsen their visual snow symptoms. Let's move to MOG optic neuritis. It is important to remember that optic neuritis is just a clinical diagnosis. It needs to be proper classifications. The first tier is either autoimmune or infectious systemic. In autoimmune categories, specific biomarker help guide diagnosis. One such a biomarker is the myelin oligodendrocyte glycoprotein antibody, MOG antibody. MOG positivity is observed in 25% of the children experiencing their first demyelinating events of isolated optic neuritis. MOG optic neuritis has traditionally considered more monophagic in children. However, long-term data reveals that the relapse risk in pediatric patients approaches that of adults over time. At 2 years of follow-up, the relapse rate is lower in children than adults. However, with 5 years of follow-up, both groups show a relapse rate approximately 67%. This suggests that long-term monitoring is important for pediatric MOG optic neuritis. In terms of relapse prevention, I believe that tocilizumab is currently considered most effective, followed by IVIG, rituximab, mycophenolate, and azathioprine. So, phase 3 clinical trial for acetylizumab subcutaneous injection is underway for patients aged 12 and older with MOG optic neuritis. I believe that good treatment for treating MOG optic neuritis will continue to evolve. Finally, let's talk about hallucinogen persistent perception disorder named HPPD in adolescents. HPPD is non-psychotic disorder where patients experience persistent visual hallucination or perceptual distortion after using hallucinogenic drugs. Adolescent drug abuse is a raging concern, even in South Korea. At least 1 in 8 teens have used illicit substance in last year. In teenagers with visual symptoms like polynopia or hallucination, it is important to screen for drug use and differentiate HPPD from primary psychotic disorders. Treatment may include mood stabilizer such as benzodiazepine or antipsychotic medication like aripiprazole. In conclusion, today we explore recent technology advancement in diagnosis and treatment and newly imaging diseases in pediatric neuroophthalmology. Pediatric neuroophthalmology is not simple neuroophthalmology for small adults. It presents unique diagnostic challenges and highlight the critical importance of early intervention to prevent lifelong visual impairment. as a technology and interdisciplinary care continue to evolve, our field is uniquely positioned to safeguard children's vision for the future. Thank you for your time and attention.
Thank you, Dr. Shin, for the wonderful presentation. I just had one question. You said visual snow syndrome has become very, very common, and most of the patients are very happy that somebody is agreeing with their symptoms. Do you know any advances in the treatment?
Oh, that's very great question. So, in my study, I believe that filter glasses provided partial reliefment in more than 40% patient, and lamotrigine, unfortunately, that's the primary medication for visual snow, but it only provide partial relief only 20%. But I believe that you're right. Most of the patients, they are very grateful for just saying that it's a disease, it's a functional disease. You are not gonna blind, and so don't worry about too much. Don't focus on the small dot, just to, see your future. So saying like that, most of the patients, they feel relieved. You're right. But I believe that in future, we also did a clinical trial for electric therapeutics, trigeminal nerve innervation therapy. So this kind of future therapeutics will treat their symptoms, not just only saying that you are not blind. Some of them really, they suffer from depression, anxiety disorder with the visual snow symptoms.
Absolutely. Any other questions from the audience?
That's a great question. If patient unilateral, that's not a visual snow syndrome. Visual snow is a brain problem. They complain of bilateral, simultaneous, similar pattern of noise and dot in both eyes. Even though they close their eye, they feel that. There's a brain hyperactivity problem, not an eye problem.
Thank you very much. Great talk. And I think I agree with you. I think many of the patients are very appreciative that we're recognizing and we're acknowledging their problems. And I've actually had some limited success with the tinted, the FL41 lenses. Thank you. The next speaker, we're very, very fortunate to have him, is Dr. Ramesh Kakunaya. He will be talking on uveitic cataract management.
Thank you so much for having me. In children, the cataract itself is very difficult. We all understand that because of age factor and the difficult association. And when there is a fire of inflammation, it becomes even more difficult. Having said that, we have to deal with these kind of patients because they might go into amblyopia if you don't treat them. So there are certain cases. Let's see. I do not have any financial disclosures relevant to this presentation, but these are my financial disclosures. We would divide this talk into 5 areas. One is just to find out what are the causes of cataract and types of cataract, what you see, and what's the best timing in terms of doing the surgery in this patient. And if you decide to do surgery, whether intraocular lens is implantable or better to avoid, and if you decide what are the techniques which can help you. And most important, we are all looking for in pediatric cataract surgery and the uveitic cataract is a long-term outcome. If you look at the causes, most often it's because of JIA related. It can go from 21% to 84% of patients with this JIA. And we also have some of the patients who are on steroid induced, because for the uveitis per se, they are on long-term steroid, and also persistent inflammation can lead to pigment deposition, and over a period of time they can develop an anterior membranous or a posterior membranous cataract. This is one of the publications from Dr. Jagatram's group from Chandigarh. You can see JIA is on the top. More than half of the patients are on JIA. And then there are idiopathic Behçet's and tuberculosis. We need to keep it in mind. And very rarely in children, HLA-B27 related, very small percentage of the patient. And what are the risk factors for developing cataract in patients with the JIA-related uveitis? Most of the times it's the presence of posterior synechia, active uveitis, and use of topical steroids. These are the most important risk factors when you look at. All of these are different, the publications. You can see the risk factor rate for this uveitis. Timing of surgery in WSPS, what we did is way back, I think 6 or 7 years ago, we developed this Delphi process for pediatric cataract management. All the experts, we asked one question: how long should the patients with JAA be off systemic medication to be considered for a good candidate for IOL? There was a definite consensus that it should be more than 1 year, though some of them felt, depending upon the age of the patient, it can be around 6 months. So here, meticulous case selection, aggressive control of intraocular inflammation, both pre, peri, and post. This is not about just pre-operative management, it has to be post. And also, these are the key factors for success. The second question asked in the Delphi process, this is already published in BJVO: do you implant an IOL in patients with the JIA without signs of ocular inflammation? Yes, some of them said yes, some of them said no. And how long you wait? Again, this is more than 1 year. The other question frequently asked is, do you use heparin coated? If you implant a lens, do you use a heparin? Almost none of the experts said. The experts are from different parts of the world, not from one part. So none of them said they are using this heparin coated, because we have other active inflammation control. So IOL or not depends upon the factors. Mostly FAKI is a gold standard in most of the patient. But if you want to place an IOL, patient selection is crucial. Good success rate have been published off late. When I say off late, in the last decade, more and more people are implanting IOL in this group of patients with the good anterior-vitrectomy and coastocapsulorhexis. And of course, you have to go for hydrophobic lenses. But word of caution, no intraocular lens with poor or difficult control of inflammation. If you cannot achieve a good control of inflammation pre-operatively for the duration of 3 to 6 months, probably it's not a candidate. And significant fibrin and post-synechia. And if you are going to implant the lens and they are not going to come for the follow-up for the next 1 month or 2 months, within that 1 month, you might lose the eye to significant visual axis opacification. So you can see sometimes the atrophic ciliary body, you can even do it, because UBM before surgery really helps in really identifying this cycliting membrane, because these information, use it as much imaging modalities as possible to decide about intraocular lens implantation. And this is again from the Jagatram's group. You can see 6% of the patients can even have cycliting membrane. And there are significant patients and publication are there whether to go for aphakia or pseudophakia. And these are the indications as well as contraindications, what you can see, and these are all evidence-based information from all the places. So these are the pre-operative intraocular lens implantation and all the things you need to take care. And one important thing is, even after surgery, you have to go for aggressive anti-inflammatory, and regular follow-up is very, very important, especially the intraocular pressure and the inflammation. And if you do a better counseling, you will have a better thing. But if you can see cataract surgery with the intraocular lens implantation, this is a very recent article in the era of biologics, you can see biologic versus non-biologics. How much improvement is there? There is a group of immunosuppressants with steroids, immunosuppressants with biologics. Biologics always improves the visual outcome, and in both the groups there is no change in the complications. Now I just wanted to show a few of the techniques, if possible, if the time permits. Sometimes it can be as white as this without much synechia. You can do the routine way what you want. You can see capsulorhexis being done in this patient. You can even stain it and then aspirate all the lens matter. Lens matter is usually rocky, it can be hard, and the pupil can, with one mild touch, your pupil can become very myotic. It's possible, and sometimes you have to do the capsulorhexis after doing the lens aspiration, because you can see one little touch there can really, and sometimes you can use iris dilators. Sometimes the intracameral epinephrine may not be enough, and you can see the fish mouthing you saw. This is very, very commonly it can happen because the iris is very, very flimsy in this patient, and that's the simple aphakia. And this patient, you can see already, you can see prior inflammation there. Try to navigate this synechia. Sometimes when you do this synechiolysis, the pupil becomes very small. That's almost impossible to do anything else. Here, can you see this plaque developed? You have to just do a plaquectomy so that you can remove the whole anterior capsule, like a plaque-like anterior capsule, and it can complete your anterior capsulorhexis. And then, depending upon the intraoperative leaf fundus also you can see, and you can see the haze there. You can also look at indirectly, or you can also do it, and then intraocular lens can be implanted at this stage. You can also inject a triamcinolone injection just to make sure that there are no, but I don't keep the triamcinolone injection in situ there. It may not be a good idea. And sometimes these are the very, very rocky kind. It's an old one. Here I would not even attempt to do any kind of intraocular lens. Just remove this. Somehow the video is not working, doesn't matter. So we just have to do a good aphakia for this patient. So that's the long-term outcome what Dr. Jagatram's group has published between the pseudophakic group as well as the phakic group, aphakic group. You can see the 20/40 vision is achieved in significant number of patients in both. So the case selection is very, very important, and these are the list of complications what you can see. So in summary, I would say lens aspiration with PPC, AV and IOL implantation can provide a good visual outcome, both from the personal as well as evidence-based. Disease chronicity, glaucoma, CNVM, and hypertony. That's why identification of that cyclitic membrane is very important. Optimum immunosuppression. You have to always work with the rheumatologist if you want to go ahead with this surgery. Pre, peri, and also post, not just pre. PPV with lensectomy is a better in certain situations, especially you need to work with the retina surgeons when there is cyclitic membrane with vitreous opacity, and also some of these patients are preoperative hypotony. So there you need to work. And all in all, I would say meticulous case selection and aggressive control of inflammation is important. Otherwise, don't even touch this patient. And I vaguely, even now I remember, one of the patient came for surgery, came for 1 week, did not even come for 6 months. Completely the eye is gone. So you need to really call these patients for the follow-up, and it's a very, very long-term disease. I just want to end here and just want to make one announcement. We have a Pediatric Ophthalmology Strabismus Network meeting happening again in Delhi in September. It'll be a fantastic meeting. And also we have a WSPO Subspecialty Day in Copenhagen. So hope to see you, some of you there. Thank you very much.
Thank you. Any?
I used to do. I don't do it anymore. If you do a good pupilloplasty, that's enough. Unless there is a significant synechia where there is a chance of anterior synechia happening, in those cases I would do it. So earlier I used to do it. One thing which additionally I will do, I did not speak, is I put them everyone on atropine after surgery, not on any other medication. So no iodectomy.
Suppose there is an anterior synechia over the IOL 360 over the edge of the pupil. So iridectomy can save that glaucomatous part.
It can, but I for the exact same reason I used to do it. Now what I do it, when I do a iridectomy or pupilloplasty during surgery, pupil becomes dilated and I put them on atropine from the table. I put them and send. So chances of iris bombay developing is very, very minimal. But at the same time, I must tell you, I don't think so there is any harm in doing a peripheral iodectomy, because it might benefit, but in my experience, I don't think so it really helps. But definitely I can say it may not harm. Yes,
Thank you.
Siddharth.
Actually, you know what?
Difference between the do the PPC and vitrectomy, and instead of doing the vitrectomy, simply do the optic capture. Is there any difference in uveitis?
I haven't studied that, but I try to do vitrectomy in all the patients, because even the vitreous is usually inflamed. If you leave them like that, it regrows and it can cause visual. One or two patients we could not do it for various reasons, so it can cause. So iris, the double capture, I'm not sure. I'm not compared it really personally.
Because if we do the vitrectomy, that will leave that barrier, the anterior vitreous phase. So it might have more chance for development of
It's all, we have to look at the risk benefit ratio.
Yeah.
Here you have to preserve the visual axis as well. So I tend to do a vitrectomy as well.
We have, sorry guys, we actually
Yes.
have to empty this room, and we have two more excellent speakers. So for the respect for the two speakers, this is a great topic, and as you know, we could talk about this for an hour easily. So we have we are very fortunate to have the next speaker talking on pediatric allergies, what is new, by Aryani Ambra from Indonesia. Thank you. And again, we'll be here after, so please come and grab any one of us. You could put up the next slide, please, on pediatric allergy, please.
That's come right. Yeah.
Good.
Okay.
Thank you.
Thank you. Good afternoon. It is an honor to be here today to share topics on pediatric allergy. I have no conflict of interest on this presentation. Over the past decades, allergic diseases in children have been increasing, including allergic conjunctivitis, which significantly impact our eye health and quality of life. Asia has a high prevalence of these conditions, influenced by comorbid socioeconomic factors and environmental factors such as climate, pollution, and organic material, which exacerbates ocular allergy symptoms. This study in Indonesia revealed that allergies increase with age. Skin prick test results show an allergy prevalence of 21.9% in elementary school children, 28.95% in middle school students, and 45.3% in university students. These trends suggest that broader allergens exposure contributes to rising cases. Allergies occur due to an aggregated immune response to the allergens, both indoor or outdoors. Common triggers include dust, pets, mold, pollen, insect, and air pollutants, which worsen symptoms like allergic conjunctivitis and asthma. Allergies are influenced by genetic, epigenetic, environmental, and immune system factors. The gut microbiota also plays a role in regulating immune responses to allergens. This complex interaction contributes to ocular allergies, allergic rhinitis, and asthma. The conjunctival-associated lymphoid tissue functions as a local immune defense against allergens in the eye. This structure contains B cell, T cell, mast cell, and plasma cell, which play a role in ocular allergic responses. There is 3 phases of allergic pathogenesis. First is sensitization, where the initial exposure leads to IgA production, which binds to mast cell. And then the acute phase, re-exposure triggers histamine release, causing itching, redness, and conjunctival swelling. And then in chronic phase, persistent inflammatory may lead to tissue damage and increased sensitivity to allergens. Allergic reaction develop in early, late, and chronic phase, involving inflammatory mediators such as histamines, cytokines, chemokines. Understanding this phase is crucial for effective therapeutic strategies. Allergic conjunctivitis is classified into seasonal allergic conjunctivitis and perennial allergic conjunctivitis triggered by environmental allergens. More complex immune-mediated conditions include vernal keratoconjunctivitis, atopic keratoconjunctivitis, and giant papillary conjunctivitis, which may lead to serious ocular complications. The conventional allergy tests include skin prick test, intradermal test, patch test, and provocation test, which help identify specific allergens. Skin prick automatic test is a modern method that provides more accurate result than manual skin prick test, reducing result inconsistencies by 34% and improving patient comfort. Skin prick automatic test is conducted through an automated process from arm positioning and simultaneous allergens injection to digital analysis for more objective result. Managing allergies involves avoiding allergens and using pharmacological therapy, including antihistamines, steroids, mast cell stabilizer, or combination therapy to control the symptoms. Allergen immunotherapy builds tolerance to allergens through subcutaneous immunotherapy or sublingual immunotherapy, which is more convenient for children. In the allergen immunotherapy, the desensitization process of allergen immunotherapy consists of 2 phases. Introduction phase, 5 until 8 months, where the immune system adapts to allergens. And then the maintenance phase, 3 until 5 years is the long-term effect developed. It has been found to be more effective for VKC and AKC. The biological agent in allergy treatment targets specific inflammatory pathway using monoclonal antibodies, providing more effective result than conventional therapy. Omalizumab, as an anti-IgA monoclonal antibody, works by inhibiting IgE and is effective for severe asthma, allergic rhinitis, and VKC that doesn't respond to conventional therapy. Several case studies highlight the effectiveness of omalizumab in vernal conjunctivitis cases that are difficult to treat with standard therapy. However, further research is needed. Dupilumab, which targets interleukin-4 and 13, has shown effectiveness in children aged 6 until 12 with moderate to severe atopic dermatitis. However, a significant side effect to monitor is conjunctivitis. Some biologic treatments can cause ocular side effects, including conjunctivitis, blepharitis, and dry eyes, particularly in patients receiving dupilumab, tracolinumab, and lebrikizumab. Close monitoring is essential during therapy. As take-home message, pediatric allergy had high prevalence in Asia, causing repeated visits to hospital, and etiology was still the main factor in managing pediatric allergy, and current treatment has shown great benefit. Last consultation between departments has been benefit, especially from pediatric and ENT department. Thank you for your time and attention.
Thank you.
So, any questions from the audience? If not, we can call upon the next speaker, or we can have questions later. I would like to call upon Dr. Sanjay Srinivasan. He is going to talk about a novel topical medication for pediatric uveitic macular edema.
Thank you, Dr. Ramesh. I would like to thank AIOS and APAO for giving me this opportunity. So, I'll be talking about a new novel topical medication for pediatric uveitic macular edema. So, I have no financial disclosures or no conflict of interest. Uveitic macular edema occurs in 8.3% of non-infectious uveitis. The thing is, it can occur even without any sign of concurrent inflammation, both in the anterior segment or in the vitreous or posterior segment as such. This is as a result of the breakdown of the blood retinal barrier and various inflammatory factors like VEGF, pro-inflammatory cytokines, IL-6, 8, TNF-alpha, IL-1, TGB are released, and this actually causes the uveitic macular edema. Now, what do we have for the conventional treatment? We have steroids in various forms, from topical, regional, depot, intravitreal steroids. We have the topical NSAIDs, the anti-VEGF, immunomodulatory agents, and biologics. This idea actually germinated from the study which was done on topical interferon in diabetic macular edema, where there was improvement, but the studies actually did not show any statistical significance. Now, how does the topical interferon act? So, it acts probably by restoration of IL-2 production, which helps stabilize the retinal barrier. The inflammatory cytokines like TNF-alpha and IL-6 are reduced, and inhibition of inflammasome activation. The inflammasomes are actually cytosolic proteins which are responsible for innate immunity. Now, there is also regulation of the VEGF gene expression and inhibition of basic fibroblast growth factor and IL-8. All this helps restore the blood retinal barrier, and also it prevents the NK cells, CD8 and CD3 cells from acting. Now, how do we do it? We have a commercially available interferon solution which comes as 3 million units per ml. The drug which we used was injection Intalpha. We took 2 ml of sterile water for injection to reconstitute 3 ml of interferon, which turns out to be 1 million unit per eye drop solution. The patient was handed over this drug. We actually estimated that the drug what we prepared was there for 2 weeks, and we actually provided ice pack to be given to the patient, because many of our patients travel long distances, and this was to be kept in a refrigerator door at 4 degrees centigrade to keep the optimal effect of the interferon. So this is the drug which we actually used. This was the one we had it. This study was done when I was in India. This was an ethics committee approved, and we actually did for adults patient initially, and with the success we actually obtained, then we actually started recruiting pediatric patients also, with full explanation of the drug and its effects from their guardians, and the study was done. Now, how did we go about? We initially started with using this interferon for pseudophakic CMOs. We used 4 times a day, and these pseudophakic CMOs were actually resistant to most of the drugs, the steroids or intravitreal or depot steroids or oral steroids. Whenever we actually stopped the medication, the pseudophakic CMO used to recur. So we also actually looked at the lens portion and saw whether the lens was actually responsible for this pseudophakic CMO, but fortunately for us, the lens was actually in the bag in the position. So we could not attribute this pseudophakic CMO to any cause. So this was one of this case. Our initial success was with inflammatory CMO in a patient with cat bite who had a panuveitis kind of picture, and this gave us impetus to actually try out on a few things. But all was not rosy, so we used the same model of 4 times a day for some of the uveitic macular edema in adults, which we define as a standard therapy. It worked in some patients, but it didn't work in everybody. So we actually went back, and we thought that probably these patients may need more intensive medication. So we tried 6 times or 3 hourly medications, and surprisingly it worked. Now I'll describe the cases which we actually used this topical interferon. This is a 10-year-old Asian Indian boy with presenting visual acuity of 20/100 and 20/200. He had multiple ocular comorbidities with deep stromal corneal scar, no ghost vessels, keratoconus, early posterior subcapsular cataract, and bilateral IU. So the systemic investigations were unremarkable. We could not find any cause, so it was more likely idiopathic. So a patient was initially started on topical and systemic steroids, but patient was not responding well. So in consultation with rheumatologist, we started with methotrexate and folic acid. There was non-compliance during COVID-19 lockdown, and patient was self-medicating. In India, topical steroids are available over the counter, so anybody can buy and keep using it. So also the patient had repeated urinary tract infections with all this steroids and methotrexate. So he went to a local doctor, and he put him on nitrofurantoin. So this happened on and off. And subsequently he developed intolerance to methotrexate. So in consultation with the rheumatologist, we actually got him on cyclosporine. Then we actually reduced the methotrexate dose, and cyclosporine dose was upped. We tried diflupred, which is actually more penetrable in the posterior segment, but bromfenac, all this didn't help very much. So a detailed discussion was done with the parents, saying that so we have tried both the systemic and ocular medications. We offered injectables in the eye, but the parent was not very keen for any injectables. This is the OCT actually showing the cystoid macular edema at presentation to me. And so this illustration, actually this is in publication, so that's why I put ABCD. So the first one is at presentation to me. Then after I started with topical interferon, you can see the cystoid changes. This is about 2 months after initiation, so the cystoid macular edema has reduced. The patient is still on cyclosporin and methotrexate, no steroids, no NSAIDs. And then I reduced the dose. The D is at 3 times the dose, E is at 2 times, and F is at 1 time. So he has remained like this with topical interferon, and finally we were able to wean him off the topical interferon. He is just only on systemic medication. So this is the final outcome we have been able to achieve with complete resolution of cystoid macular edema. The second case is a 12-year-old Asian Indian girl with bilateral panuveitis diagnosed in 2017. She was treated elsewhere. Surprisingly, only her right eye used to get cystoid macular edema. Again, the systemic workup was negative. She had also posterior subcapsular cataract only in the right eye. She also had a few episodes of vitreous hemorrhage which resolved on its own. Initially started on 7.5 milligrams of methotrexate up to 20 milligrams. Funnily enough, this patient used to have recurrent herpes simplex infection of her lips. So this made the clever father to actually stop the methotrexate and start the acyclovir again off the counter, because once I had started, then he used to do it on his own. And when the cystoid macular edema recurred, he used to turn up and see me. So this patient also I started on, this one was quite thick actually, the cystoid macular edema. Again, with the initiation of topical interferon, it gradually reduced, and it's quite resolved after about 5 months. The third case was a more challenging case of a bilateral panuveitis with secondary glaucoma and cataract. At her presentation elsewhere, she had a vision of counting fingers and 1 meter. Intraocular pressures were also very high. So these were the procedures done. So she came to us when she had been on oral steroids, topical steroids, and persistent systemic cystoid macular edema. So after initiation of topical interferon 1 month later, there was some reduction. But unfortunately, 2 months later, this again recurred despite using the topical interferon. So in summary, I have these 3 cases, which 2 cases had very good improvement, and there was no recurrence after initiation of topical interferon. All these patients were still on the systemic immunosuppressants in the same dose, and there was no additional medication which was given. Just to give a brief on interferon, it's a large molecular weight substance which actually, when you put it in the eye, because of poor conjunctival and corneal penetration, we are not still sure how it's actually acting. But probably there is a mechanism of sclera which is allowing it to actually enter into the posterior segment. Also, this was explored by my colleague who tried posterior subtenons for one of the cases which was published earlier this year. There have been newer agents for uveitic macular edema, including faricimab. So this actually helped in resolution. So probably in our cases, none of the guardians were actually in favor of getting any injections. So that is why we did not proceed with injections for them. So the limitations of this is it's a short case series. It worked in 2 patients with pediatric uveitis. It's an off-label drug. We didn't have any complications. The complications in some of our elderly patients were like conjunctival congestion, punctate epithelial erosions, photophobia, some lid swelling, but in our both pediatric or all the 3 pediatric patients, we didn't have any of those complications. So probably we can explore this as an effective alternative for treating persistent CMO in pediatric patients, and it is also helps to reduce the dosage of topical steroids. So I'd like to invite you to the 35th anniversary meeting in Singapore next year. Thank you.
Thank you. Well, I know some of you have to leave for the next session, and we have to empty this room in 5. There's a next session that's going to start in 5 minutes. So we'll be outside. If any one of you have any questions, please come to any one of the speakers for any additional questions. Thank you very much for attending the best symposium at the APAO. Thank you.